Ask everybody to go ahead and take their seat. And anybody that was standing before, I think there's a couple of seats available. And feel free to, if you want to come closer, whatever you're comfortable with is fine. We're going to start the afternoon presentation. I hope you all had a good lunch. Thank you. I especially like the zucchini. It's quite tasty. We're going to switch gears again. I know we've switched gears quite a bit this morning, and I hope you guys appreciate the fact that we had very diverse speakers taking us in some different directions. We're going to go in another direction now, and we're going to have a panel discussion around the End of Life Option Act. And some people might be asking, well, what is this doing at a suicide prevention conference? And I just want to tell you for a minute how this came to be, because when we were talking about putting together the conference this year, I was talking with a physician who brought up this issue, and I said, physician-assisted suicide. And she said, no. I said, well, that's what it's called. And she said, yeah, and that's a problem. There are a lot of people who believe that this is suicide, and that it is the same as other types of suicide that we've talked about. And so it's one of the things we want to start having a conversation about is what is the End of Life Option Act, and how does it compare and contrast to what we've been talking about this morning, which is suicide as a result of mental illness or depression or a number of stressors that people might encounter in their life. This is something very different. So we are very blessed to have an amazing panel this morning. They come to us from the City of Hope. Dr. I hope I get your name right. Jaroslava Solomon, there we go. You normally don't get to say the L in Solomon's. She is an assistant professor of psychiatry at City of Hope. She specializes in consultation and liaison psychiatry, which is, for people who aren't familiar with that, that's helping medical patients who develop mental health issues or challenges. And then with her, we have Victoria Ramirez and Blanca Rivas, who are both licensed clinical social workers and program leaders for the End of Life Option Act at the City of Hope. They have over 13 years working together in oncology. Blanca has a specialty in both breast and neurological cancers, and Victoria has a specialty in neuro-oncological cancer and melanoma, and both believe strongly in empowering their patients to have open conversations about end of life. So again, we're at the point where we're going to talk about having courageous conversations. These are not easy conversations to have, and they're going to help us figure out how we go forward on some of this and help hopefully answer a lot of questions for us. So I'm going to turn the floor over to Dr. Salmon. Thank you.
Thank you very much. Thank you for inviting us to be here and be part of this wonderful conference. It's really an honor to be here. Let me figure out the... Here we go. I have no conflict of interest to disclose. So before we start, I would like to invite you just to pause and think introspectively a little bit. If you've ever gone to the Museum of Tolerance in Los Angeles, you may have been not confronted, but you may remember these two sets of doors that say one prejudiced and another one unprejudiced, and the guide will tell you, well, think about which door do you think you could go through or should go through, and think about that, which door would you choose for yourself? And then the second sign turns on that says, now use other door. Whether we like it or not, each one of us, including myself, are prone to having biases and prejudices and beliefs that we hold dear to ourselves. And they might come from our background, from the family surroundings and other people that influenced us. And the topic we're going to talk about today is one of those topics that often is really, really charged, emotionally charged, and people have very strong opinions and strong feelings about it. So what I would like to do is to ask you to let go, maybe whatever feelings or thoughts you have about this topic, let go of that, open your mind and just listen. And our goal and hope would be that when you leave the conference today, you will feel empowered by the knowledge that you've gathered throughout the day. And then wherever you work, whatever your personal or professional world is, that you can make a positive impact and encourage these difficult conversations with your friends and colleagues. So medical aid in dying is still one of those controversial, very controversial subjects. And philosophically at the core are two main questions. One, is some type of medical aid in dying ethically acceptable or ethically mandatory in certain cases? And two, should some type of medical aid in dying be legally allowed, and if so, under what conditions? And this controversial debate has been ranging for decades, even longer perhaps. And very generally speaking, you could think about sort of two camps of thought on this. One that we might refer to as more liberal approach, where the main concern is to allow people to have their autonomy, to exercise their autonomy, to decide when and how they want to end their life. And on the other hand, more conservative approach where the arguments are about what is the proper role of medicine and the proper role of physician. Could something like that lead to slippery slopes? You may have heard that term, where we all of a sudden start using this method in people who cannot perhaps make a decision for themselves. How about the sanctity of life? Do we have a right to end our lives or allow somebody to end their lives this way? And over the decades, despite this debate, there hasn't been much of a progress as far as sort of bringing these camps together. And if anything, people seem to get more entrenched and just develop more stronger arguments against the other one. But what we are hoping for is, one, to be personally more aware of our own opinions on the subject, and especially if you work in healthcare and you're a physician or a nurse or a social worker, chances are that patients or families will bring this up. And you want to be equipped with knowledge. What's out there? What does it mean? What is the data so far? So that when they do have questions and they ask about it, you can provide them with accurate information. So even though we have very differing opinions about this and very strong opinions in general public, but also among experts, we live in a democratic, at least we hope so, right? Democratic society that allows us to pass laws despite these unresolved discussions. And I can tell you, I grew up in the communist country, so I know what it's like to live in a place that does not allow freedom of expression. And one of the beauties of our society that I think we all have to cherish and protect is the ability to have these difficult conversations without being a threat to each other, with mutual respect, and be able to apply critical thinking to what we're talking about. And what does that mean? That we are basing our ideas and arguments on facts and not really on the strong feelings, right? Because the strong feeling does not equal a fact. Now, in some states in the United States, this act is still considered a manslaughter. Interestingly, the Gallup poll from last year, when they, and I don't remember the number of people that they polled, but it showed that there has been an increasing public support for euthanasia. Now, mind you, euthanasia, and I'll talk more about that term, is not legal anywhere in the United States. But there's been an increasing public support for euthanasia. About 73% among, about 60% among the groups that identify themselves as more conservatively leaning, and 89% about those that identify as more liberally leaning. Now, part of why these numbers are so high, at least I think they're pretty high, could be what's called a framing effect. So depends on how you phrase the question in the polling. It can impact the numbers, because if you ask the question without using the term suicide, then the numbers are going to be higher than if you phrase the question by using the term suicide. Okay. Now, the End of Life Option Act in California passed in 2016, came into effect in 2016, and in general implies that the physician prescribes medication to a mentally competent, terminally ill patient, which the patient may ingest to bring about a peaceful death. And some of the concerns that have come up over the years and continue to come up are about protection of people. Do statutory safeguards protect vulnerable patients? And do patients participate in this because they lack access to health insurance or palliative care? Right? Are you wondering still whether that's the case? One of the things that we would like to emphasize here is the importance of the words that we use and the terminology that we use, because semantics can have powerful impact, right? Somebody very wise once said that the word is more powerful than a sword, and it's true. So you may have heard other terms like physician-assisted suicide, physician-assisted death and dying. That's very different from, or still different from euthanasia, when euthanasia means that whether it's a nurse or a physician will actually administer the life-ending medication to the patient. Okay, so they actively will give it to them, whereas in physician-assisted death, generally that implies that the physician may prescribe it, but the patient will take it. Many people still refer to the End of Life Option Act or its versions, because it has different names in different states, as assisted suicide. And I put it in quotation marks because really what we would like to encourage, especially in medical communities, to use the term medical aid in dying. Why is that? The term suicide doesn't necessarily reflect what the patients and the families actually experience. And some patients and families find the term applied to them who want to participate in this act as implying a mental disorder or a desire for self-destruction, and find it actually offensive. So the term assisted suicide really is inaccurate and can be incendiary. However, unfortunately, in groups that continue to use this term, they may use it, and I've read it in some of the articles on primarily religious websites, where this kind of a law will encourage and normalize suicides in general, which in fact in studies has not shown not to be true. And it is the term that's often used by people who oppose the law itself. So what does the data tell us? As you may know, Oregon has over 20 years experience with this law, and between 1997 and 2017, almost 2,000 people received a prescription for life-ending medication, and about 2/3 of them died from ingesting the medication. As far as the demographic profile, who are the people who got the prescription? Most of them had an underlying terminal cancer. Most of them were non-Hispanic whites, over 90%, 65 years or older. Most of them had college or higher education, and the majority was enrolled in hospice. Most of them died at home, and the vast majority had health insurance. And the top 3 reasons that these people listed for why they wanted to die this way were loss of autonomy, less able to engage in activities that make life enjoyable, and loss of dignity. So not even pain, for example, right? Or really a desire to die. California End of Life Option Act because it came into effect in 2016, we only have 1 year and something experience. And this is the 2017 data. 577 patients in California received the prescription. 374 died following the ingestion, including 11 patients who received the prescription in 2017. And look at the statistics. It's very similar to what Oregon has been showing. So 80% are 60 and older. Most of them are white. More than half are college or higher education, have a college or higher education degree. Vast majority has health insurance, and the majority is receiving hospice and palliative care. As far as the diagnosis, the majority of these patients have cancer. Interestingly, more females than males receive the prescription. So the concern that minorities, disabled, poor, or other socioeconomically marginalized groups might be pressured to accept medical aid in dying so far has not been borne out by the data, whether it's the United States or even European countries, and some of them have, in some of them euthanasia is legal as well, as it is in Canada. This is the breakdown of major illness categories for End-of-Life Option Act individuals, and you can see that the majority of them have cancer. And some of the other ones are neurological disease, such as ALS, that's pretty typical one. Cardiovascular disease, chronic respiratory disease, or cerebrovascular disease. As a psychiatrist, I will talk briefly about mental health evaluation for these patients. Most of the states that legalize this act do not require a mandatory mental health evaluation. I think with the exception of Hawaii recently, that they want these patients to have mental health evaluation by default. However, the patients can get referred for mental health evaluation if the primary physician or the consulting physician or perhaps a social worker, somebody who's interacting with the patient or the family, gets an indication that they could be seriously depressed, and that could be impacting their decision and their request for this. So that's an option by referral, but not by default. The downside is that non-psychiatrists are not very good at recognizing clinical depression. So you may say, well, is it possible, if not everybody gets seen by a mental health professional, is it possible that we miss people who may have some serious clinical depression? And if we treated them, perhaps they would change their minds? It is possible. It's probably a small percentage of patients who fall into that category, but it's definitely possible. Who should do the mental health evaluation of these patients? It should be a licensed psychiatrist or a psychologist who is experienced in evaluating medically ill patients and evaluating cognitive capacity to make a decision in medically ill patients. There are no formal guidelines on how to do this type of mental health evaluation, and I think it goes without a saying that it should not be the patient's own psychiatrist or therapist who should comment on this or do that evaluation, right? If the patient already has a psychiatrist or therapist, for the purpose of this kind of evaluation, if it's needed, they should be referred to someone else who can do a neutral evaluation. Does it make sense? Yeah, okay. So in summary, there's been an increasing acceptance of medical aid in dying as far as general society. It is still, however, a very controversial topic, and I don't expect that we'll have some universally accepted consensus on this. It certainly brings new challenges to medical providers about how to respond to patients' questions and requests about this. And again, I think it's really important for us to be able to provide accurate and up-to-date information to them. There are definitely opportunities for further research to inform our practice and learn from this, because the law is in place. People are take advantage of it. So what do we learn from it? And let us forever, every day of our personal and professional lives, be aware of what our own strong convictions are and how they could impact how we talk to patients and talk to our colleagues. And I'll leave you with that and pass the microphone to my colleagues, Victoria and Blanca.
Okay. Thank you, Dr. Salman. Just again, I would like to introduce myself, Victoria Ramirez, and my colleague, Blanca Rivas. We are the designated End-of-Life Option Act social workers and program leaders at City of Hope. When Dr. Salman began her presentation, I just wanted to take you back to the visual of the two doors, the two entrances, and a reminder of our biases and prejudice, while encouraging us to listen with an open mind. What Blanca and I would like to do is take you a step further with this illustration, the elephant in the room. So we have our elephant sitting on the couch, and he's saying, "I'm right there in the room, and no one even acknowledges me." So in our experiences as oncology social workers, there aren't many people who voluntarily want to discuss death. It is the elephant in the room. We talk about I think I pressed the button. We talk about the fight and bravery and treatment, of course. However, what we don't talk a lot about is how much bravery it does take to inquire about the option to end suffering once you have been given a poor prognosis. A brief example, I had a patient who called in directly to the social work office because he was hesitant to bring this up with his own physician that he'd known for a few years. He was fearful about what his physician might think and what his response would be, and would that impact his treatment somehow. Many of you have heard of medical aid in dying, maybe even heard of the statistics that were released that Dr. Salman just went over after the law was passed in California. What we would like to do now is provide a closer look at the process and the patients who inquire about medical aid in dying. We really hope to expand on the patient experience throughout this presentation. We do not have anything to disclose. And then briefly, this is what we're going to discuss: the California law and eligibility. We'll talk about the procedure at City of Hope, our data, some challenges and benefits. Blanca will discuss case studies. We really would like to tell you about an important resource called Compassion and Choices, and then of course have some time for discussion. So the California law, it was passed in June 9th of 2016, and it allows terminally ill, mentally capable adults with 6 months or less to live to request a doctor's prescription for medication that they could decide to take in their final days or weeks to end unbearable suffering and die peacefully. Recently, the End-of-Life Option Act, or EOLOA, was in the news. The law is still in effect, but there was a lawsuit, and Riverside County attempted to invalidate EOLOA. So there was a motion filed. However, a stay was granted by the California Court of Appeals. So while they are still deciding, patients can continue to access and receive prescriptions for the End-of-Life Option Act. Eligibility, when we talk about who are the patients that can make this request, we're talking about adults 18 and over with capacity to make medical decisions. We also talk about that they've also been given all of their options, including palliative care, hospice care. They have to be a California resident. They must have had a diagnosis of incurable and irreversible disease, which can, within reasonable medical judgment, will result in death within 6 months. And this has been decided by 2 physicians throughout this process. It has to be a voluntary request directly from the patient to the attending physician. It can't be requested by a family member. It can't be placed in an advance directive. It has to be verbally coming from the patient. They also have to be able to self-administer and ingest the aid in dying drug. So now the procedure. Can kind of get it's a lot of information to present because it is quite a process that they have to go through. They do have to make the patient 2 verbal requests to attending physician. So sometimes they might make a request already, but maybe their physician is not a prescriber. So they can then have to make 2 additional requests after that. They have to make a written request. They're also given a referral to a consulting physician. So another physician besides the person that's prescribing the medication. As Dr. Selman said, the mental health evaluation is only done if it's indicated. If the physician feels that they need to go this extra step in the process, that's decided on a case-by-case basis. All eligibility has to be confirmed. Proper documents have to be completed. Then the prescription for aid in dying is written. There's also some follow-up documentation and a notice of patient's death when that happens. Now I'll read for you the City of Hope statement. The law was passed in June of 2016, but City of Hope did not go live with their own policy until December 1st, 2016, so end of the year. Consistent with our mission, City of Hope is dedicated to providing the best care for our patients as we treat their physical, emotional, social, and spiritual needs. However, City of Hope also recognizes and supports a patient's right to self-determination through use of advanced care planning, e.g. advanced directives, supportive care, providing effective pain and symptom management, and offering other social, spiritual, and pastoral care support and services, including referral and access to hospice. Therefore, and after multiple thorough discussions, internally and externally, of the implications of the End-of-Life Option Act, the medical staff and executive leadership have decided to abide by this law at City of Hope. We have developed a policy and plan which will allow patient access to all supportive and palliative care, including the option provided under the new law, which will be available for those patients who have been actively cared for at our institution. So the policy, it's implicated at City of Hope, the National Medical Center, our main campus, and the Medical Foundation, because there are other locations throughout Southern California. Physicians have no obligation to initiate a discussion about EOLOA. The policy does not preclude application of or replace other existing policies of pain management, the advanced care directives like we mentioned in the statement. There are 3 locations that do not participate, which we've listed there. The law on biases. So participation for physicians, for anybody at the institutions, is voluntary. However, providing information or a referral is not considered participation by the law. So, those physicians that do not participate, they still have, the patients still have the right to ask about this. They should always contact us, and which is why we designated the 2 of us, so that they can leave the patient and the patient can continue through the process and they don't have to be a part of it if they choose not to. Eligibility at City of Hope, like we said, they have to be a current City of Hope patient receiving active treatment or care for terminal disease. We don't accept new patients just because they need to ask for the End-of-Life Option Act. And of course, they must meet all the California requirements. So Blanca and I, what do? Our social work role in this is that we're the first responders with regard to providing education and guidance. So anybody that has a question about the End-of-Life Option Act, whether that be patients or families, sometimes staff, colleagues, physicians, they're curious about it. Someone has brought this up to them and they want more education. They come to us and we guide them. We coordinate and attend all appointments for EOLOA, and we follow the patients and caregivers closely throughout, from their initial education all the way to when they receive the prescription and afterwards. I won't go through all of this, but we wanted to give you an idea of just how complicated it can be, and which is the importance of our role is to guide both the patients and the physicians, because it's a lot of paperwork, it's a long process. So we want to make sure that everything is done the way that it should be.
I think what it also does is it demonstrates it's a thoughtful process, and it doesn't happen immediately. And for some patients, this can be a little distressing. But we also have to educate them and let them know that this is also for their protection as well, to make sure that we are crossing all our T's, dotting all our I's.
It has happened before where, they get to the point and they really want to request this, but we have to remind them, this is going to take time, but we're going to help you through it. And the same with the doctors, they're ready to write the prescription, but it's like, no, there's a certain process that has to be done. The medications and cost. So I'll talk a little bit about the medication that we use for the patients that we serve is secobarbital. And to give you an idea, it was patented in 1934, commonly used as a sedative. The prescription is 100 tablets of 100 milligrams each, mixed with 2 to 4 ounces of liquid. So they are the little capsules. Each capsule of the 100 has to be opened and put into a cup and then mixed with the liquid. The out-of-pocket cost is approximately $4,500 now. Medi-Cal does provide coverage because it is a state program, but no federal money is allowed to be used because it's not countrywide. So Medicare, the VA do not participate, they do not cover. Private insurances have their own policies and the copays can vary.
So Dr. Salmon spoke a little bit about what the top 3 reasons were, and I actually have a chart that gives you more information in terms of all of the reasons that we document. The California Department of Public Health also requests this information, and unfortunately I'm unable to provide you that data because although they've given a report for 2016 and 2017, they have not provided this particular piece. But if you look at it, this really gives you a picture into what people are experiencing when they're asking for this medication and when they're thinking about not wanting to live anymore. And most of it is really a lack of being able to enjoy their life, a loss of autonomy, a loss of dignity. Many of the patients that I have seen are older patients who live independently. They were very often I can almost say there's like a prototype. They're very detail-oriented. They're very structured. They are the type of person that kind of checks boxes, and they've already got their burial arrangements done and their advance directives. So for them, this is also a way to maintain control in a situation that they feel they've lost their sense of control. Since December of 2016, when we went live with our policy, we have seen 72 patients who have requested the End-of-Life Option Act. And very similar to the data that Dr. Salmon discussed, it is almost half and half men and women. It is primarily white, and most of them have come from medical oncology, and that would be more of the solid tumors. I had originally had a slide that I usually use where it has the data from California in terms of the breakdown of the cancers. As you saw, Dr. Salmon showed the big, huge graph that showed cancer being the primary, or not the primary, but the largest population requesting this. In that data, it also showed that head and neck cancers and lung cancers were the highest. I believe lung cancers were 17% and head and neck were 12% in terms of those prescriptions that were written in 2017 for California. In terms of our data, of those 61 medical oncology patients, also for us, head and neck was the highest, as well as lung cancer. So what happened with those 72 patients that did come to social work and ask about end-of-life option act? Most of them were education. And when we mean in terms of education, it may have been that they just wanted to have general knowledge about it. They wanted to know that they'd heard about it. They want to know how it works. It's something that maybe they wanted to put that information in the back of their mind in case they needed it in the future. For some, unfortunately, education meant that they weren't able to go further. They were too sick, or perhaps they were discouraged by their physician, or they were discouraged by their family. And that would be kind of the people that I mentioned there who changed their mind. In terms of prescriptions that were written, there were 14. Some patients aren't able to complete the process. They may have made that first verbal request to their attending, and they were waiting in that 2-week period that you have to wait before you can make your second verbal request, and they may have been too ill to even come to the hospital for that appointment, or maybe they died while they were in process, and that was the case for about 3 of them. Of the prescriptions that we wrote, what happened? 7 actually did take the medication. They died very peacefully at home. They all had hospice. I want to let you know that all of these patients that got the prescription, all of them had their family on board. Each one of them came to their appointments with their family. Each one of them had their family come with them to come and hear the pharmacy education once they dispensed the medication. Their family was there taking notes, trying to figure out how to mix this medication, because every time they hear about the 100 capsules dissolved, they always want to know, how long is this going to take? Because there's all this anxiety that, you laugh, it's true. There is a lot of anxiety around this. In fact, we had a patient who was in her late 90s, mid 90s, and she had really bad arthritis. And she was very concerned about how she was going to open 100 capsules on her own. And Compassion and Choices, the organization that I'm going to talk about, actually provided a volunteer to assist her in that process so that she wouldn't have to, for her it was, she didn't want to burden her son and asking him to mix it for her. So 3 of the patients that got the prescription died at home without taking the medication. I think this is important to highlight in terms of the data that also Dr. Salman discussed, where not all of the people who received a prescription used it. For a lot of these individuals, it's again that sense of control. And there's a lot of anxiety and distress about what may be, what is it going to be like at end of life? Am I going to be in a lot of pain? Am I going to be suffering? Is this going to be completely unbearable? And for them, knowing that they have this prescription on hand just in case relieves a lot of that distress, because they have their backup plan. And for them, in their mind, they're not going to suffer. We have some patients who currently have the medication in hand, and kind of going back to what the cost is for, now it's $4,500. When we first started in 2016, it was actually just a little over $4,000. So the price is going up, and I don't know why. But this is a lot of money for people who are on Medicare, on a fixed income. How are they going to afford this? We had a patient who, this was a breast cancer patient who said, "What is this? Death for some with dignity?" And unfortunately, this is the cocktail that we feel is the safest to use for our patient population. There are other medications they can use, such as a morphine cocktail. But for most of our patients who have, who are at end of life, they're using a lot of pain medication, so they are no longer opioid naive. And the other cocktails we feel are not safe for them. However, with this one patient, she had not used pain medications, and she was lucky enough to be able to get the morphine version, which costs less than $3. It's completely unfair. And so, but she actually ended up dying on hospice without using the medication. She had had a lot of concern about what was hospice. Will hospice really attend to all of my needs? And I was really happy to hear that she actually felt that she was not suffering and she was able to die without using the medication. So these are some of the statements that many of the patients have said, as they're talking to us. When a patient comes asking about the End of Life Option Act, they're immediately referred to the clinical social workers, and we will provide education and we will screen them, and then we will refer back to their physician to see if they're a participating physician, or we will refer them to a physician that will prescribe. And so in that screening process, we're gathering information. What are their motivations? What's going on in their life? And these are very powerful. I can be in control of something that is inevitable. My family can plan. I watched a friend die of a very painful terminal cancer. She asked for this drug when it was too late. I'm not sure that I will ever use it, but I want to have it just in case. I don't want to put my wife through a prolonged death. And some of those concerns also come because many of these people who are at this place in their life, facing a terminal diagnosis, many of them have also been caregivers for family members who also had a terminal cancer diagnosis. So they know what it was like to be there as a caregiver, and they have this concern about being a burden on their family or suffering the way that they saw their loved ones suffer. So definitely there are still a lot of challenges and things that, we're wading through as we're going through, this new End of Life Option Act. Definitely really kind of thinking about our language, as Dr. Salman said, the stigma of the term physician-assisted suicide. We also, when we're meeting with the patients or when we're working with our physicians and staff, we're clarifying a lot of well-intentioned information. A lot of people think that if you use the End of Life Option Act, that you're going to lose your life insurance because it's considered suicide or et cetera. They think that that's going to impact them in some way in that manner, and I just want to let you guys know that that's not what goes on. Their death certificate, what goes on their death certificate is the underlying diagnosis that they had. So if they had a terminal diagnosis of cancer, their death certificate is going to say that they died of cancer. There's not going to be any mention of the End of Life Option Act on there or the aid in dying drug. We, in this process, also have encountered that as much as we are a participating hospital, we don't have that many prescribers. We had, when we first started, we really had only 2 prescribers in the whole hospital who would prescribe to any patient. We had some physicians who would prescribe only to their patients. And now I'm happy to say that the amount of prescribers for the hospital now are up to 4 or 5. Make these appointments as scheduled, 16 days apart. But if we don't have physicians who can do this that are available, then we start adding more distress to the patient. And this has happened where we were having a very difficult time trying to even find a room for a physician because he was scheduling outside of his usual template. So it can be very distressing. In terms of serving the community practice sites, it's a whole other ballgame, especially if a patient is coming from a community practice site that doesn't have a prescribing physician, then they need to be referred to the main campus, and that creates a whole slew of red tape in terms of insurance authorizations. So it's not a perfect process yet. We're still learning and trying to figure out how to streamline it. And as we mentioned before, the out-of-pocket cost for the aid in dying drug is exorbitant for people who don't have Medi-Cal or who don't have the financial means to pay for it. But the benefits are that it has really prompted us to discuss end-of-life planning. This is patient initiated. I think it's really stretched physicians and nurses to talk about this earlier on. Maybe a physician may not be ready to talk about what may possibly be their prognosis. Maybe they're still going over, well, we could provide this treatment or we can work on this. And if the patient initiates this discussion ahead of time and tells them what's important to them in terms of quality of life over quantity of days to their life, then it really becomes a much more patient-centered, tailored experience for the patient. It really honors and values their self-determination. And even in those cases where we may not have been able to refer the patients to continue on the process to acquire the medication, just the education alone was very empowering. And that was therapeutic in and of itself. And unfortunately, for example, there are some patients who may be eligible kind of on paper for every reason except for the fact that, let's say they had a GI cancer and they wouldn't be able to process the medication. And so that made them ineligible. And the other thing that I don't think we mentioned yet was when we have a patient go through this process, usually our consulting physician is a supportive medicine physician, which is a palliative physician. So this is an opportunity for us to meet with the patient and really see how we can streamline their quality of life. Can we improve their pain? Are they experiencing depression? Nausea, vomiting? How can we improve their days and just really kind of make them feel better? So I have a couple case studies that I was going to go over. This is all, I was talking to Dr. Salman right now, and we were talking about some of the cases and some of the really unique and just beautiful people that we get to work with. And it's not all, this is really sad and this is, suffering. There are some really wonderful people who, although they may have a terminal diagnosis, they have an amazing sense of humor, and that's part of their coping mechanism. That's part of their coping skills. That's how they've come this far. And I was telling her about a patient that I have that is just so funny. She calls me and she'll leave a voicemail message and say, "This is your favorite terminally ill cancer patient." And she's so wonderful. So this gentleman was a 96-year-old widowed male. He was diagnosed with metastatic scalp sarcoma. And he was actually doing quite well, living independently. His daughter lived in an outside county. He'd lost his wife many, many years ago. He was a very kind of tough guy. He'd been a fireman. And as soon as he found out that he had metastases to his brain, he decided that he really wanted to make sure that he went through this process. And he wanted to make sure that he was really able to remain mentally intact. For him, that was maintaining his dignity. And he came to his appointment with his daughter and his son-in-law, and they were very supportive, and everybody was really valuing how important this was to him. And so he actually set a date, and I remember talking to his daughter, and she was kind of preparing for that, and she said, we're going to meet ahead of time. The hospice nurse is going to be there. And afterward, when I spoke to her on the following day, she told me that it was such a great experience. They sat down in the morning. She said actually he was still in control of everything, to the point where he said, "You have to be here at a certain time, and we're going to first go over the logistics of where the will is, et cetera, those kinds of things." And then they sat down and they looked at photographs. They shared memories, and she felt it was such a beautiful experience, and the fact that she was able to prepare and plan for it. And she has been so appreciative of this that, she's actually asked to meet with all the members of the team that had assisted them in this process, because she wanted to come on campus and give us all a hug. So this kind of gives you an idea of how meaningful this is, not only for the patient, but also for the family. This, I think, is probably the youngest patient that we've had. most of our patients, very much like the demographics that Dr. Salman discussed, are a lot older, in their 70s. But this patient was, she had a 42-year-old single female. She had metastatic lung cancer, and her health had been declining progressively. It was a rather aggressive cancer, and I believe it had started it had metastasized to her spine, and so she was starting to lose mobility in one of her arms and also in her legs, and she had a lot of uncontrolled pain. As much as the pain management team was involved, really trying to figure out a regimen that was going to be able to keep her free from pain, it was just always challenging. They were always trying to keep up with it. So eventually, during one of her hospitalizations, when they were starting to talk about hospice, she had a second conversation with us, and she said, "You know what? I just want to hear about it. I'm not ready to make a decision." She was also a very detail-oriented person. She just wanted to hear all of her options. She was overwhelmed by everything that was going on in terms of, oh my God, they're talking to me about hospice. I'm just still trying to figure out, if I'm going to be able to manage this pain. And so we had a conversation, and she said, I'll let you know. And she went home on hospice, and about a week later, she called and she said, I want to do this. And she was so committed to this, despite having a lot of, or rather, very limited mobility. She had a team that her caregivers were she called them her tribe. They came with her. There was about 5 of them came with her to every appointment, and really surrounded her with a lot of support, and to the point of helping coordinate, because she couldn't walk anymore and she couldn't even be in a wheelchair and she couldn't travel in a car. She came in a gurney transport non-medical van to come and make these appointments, because she really was very committed to, I don't want my friends waiting for me to die. And instead, she had a party. Before, it was I think 2 days before the date that she planned, she had a party. She saw everybody, and they were all able to plan and prepare and process together. It was quite lovely. So there is an organization that I mentioned, I touched on. They were the organization that had volunteers that helped that patient open the pills. They're called Compassionate Choices. They are a national organization that supports people's end-of-life planning, end-of-life dignity, medical aid and dying, and they support all of the states that have laws, and they're also legal advocates for states that are looking to get these laws in other states. They also offer doctor-to-doctor consultations. So there may be physicians who are curious, maybe they want to participate, they want to prescribe, but they don't know how it's done. They want to talk to somebody who's done it. Compassionate Choices has physicians who are volunteers who will assist with that. If you want to have education or a presentation at your organization or your institution, they will provide a volunteer to come to your institution to do that education. They actually were recently at Cancer Support Community in Pasadena a couple weeks ago and had a presentation there. Again, they also have volunteers. So, for example, this hasn't really been the case for our patients in terms of not having a loved one or a caregiver present, but they also have volunteers that can be there with the patient, the individual, so that they're not alone, or to assist them with practical things. I've had them involved with a couple cases, and more for support for the caregiver. Let's see. So I think, I don't think that I could truly capture, what it's like to provide support to these patients, again, as they're courageously, facing the elephant in the room and bringing it out into the open and talking about not only their own end of life, but also what they want to do in terms of medical aid and dying, and wondering how their physician is going to receive that and how their loved ones are. But I hope this gave you kind of a little snapshot, and we are definitely available if you have any questions or you'd like to connect with us. Thank you.
Are there any questions? Yeah.
I'm a psychologist in private practice. What does the law say about a therapist in private practice or in any setting bringing up the law to clients who often are not aware of this law for themselves or for their loved ones? Are we allowed to bring it up and educate? Not obviously not convince or try to convince, but just bring it up, or we are not?
The law does not forbid anyone from bringing it up. Individual institutions may decide in their policies whether this is something, how they want to address that. For example, at City of Hope, we are not required to bring it up, and generally we're not encouraged to bring it up either. So we are kind of guided that if the patient brings it up, we want to be ready to refer them properly to get the information that they need. But the law does not ban anybody from bringing it up. Is that the answer to your question? I think, yeah. Thank you.
Yes.
There was a question.
I thought you, yeah.
Oh, I thought it was him. I'm a gerontologist, and in my many years of working with older adults, oftentimes the concept of hospice is not brought up. So when you have the medical facilities who are not going to participate, do people, and of course, are people in your institutions helping to educate the patients and their families about hospice and encouraging that more? Because the statistics are that people, will use hospice like a week before they pass. So that's my question.
So definitely, especially, in terms of the context of the conversations that occur when patients are requesting the medical aid in dying, that is part of the conversation. It's actually written into the paperwork, the documents, in terms of the checklist of items that need to be discussed in these consultations with the patients. But I think, though, what you're talking about is also a larger issue. I think that in general, when we talk about this in terms of bringing up hospice, I think we can always do a better job. The social workers are always having conversations about how we try to help our physicians go there and have this conversation, because some are absolutely excellent at bringing it up ahead, like sooner than later. But yes, we do sometimes experience, like you mentioned, that they're going home a week or two before they die, when actually they could have had this service a lot sooner.
And I just want to emphasize that these are two separate concepts, right? End of Life Option Act and the issue of palliative care, and when that is brought up and introduced to patients and families, that's a whole other issue that we're all, as a society, are still struggling with, because as a society we have such a hard time accepting our mortality and the fact that we're all gonna die.
This question for the social workers: are there any financial resources for the patients that cannot afford to pay for this medication or do not qualified for the other aids?
Go.
Yeah, I was just gonna say, at this time, we don't have any places that can help them financially with that. I did have one patient that, I don't remember what her insurance was, but the doctor was able to at least write like a justification for why she prescribed this, why, so we can certainly, including the physician that prescribed, go back to their insurance and ask for a justification, or write a justification of why they're asking for this. And it has been granted in, I think, two cases.
Right, those would be like the PPOs. But for the patients who have Medicare and that's all they have, then it's at this time, we have not found a resource. And actually, we were having a conversation. There was a webinar with Compassion and Choices, and everybody was talking about how challenging it was. And that was one of the questions, like, what are the resources out there? And at that time, nothing had. Yeah.
I just had a question about the prescription itself. I know it hasn't been prescribed as much, but how long does it take? Because I know that they can go and fill the prescription when they feel that it's necessary. So how long do they have until it expires? Or
So we had this conversation. I think they were saying like 6 months. So if they have the script, just the script without filling it, we just recently had a patient ask for a renewal of the script. So we provide a renewal if they've just been handing on the script. And I think it was the pharmacist that said that it would be like a 6-month shelf life also. So even Compassion and Choices has said for those individuals who it's a financial hardship, that it's probably a good idea to just hang on to the script and not fill it until they actually think that they're going to use it.
I have a question. Do you run into any problems with patients with their religion not supporting this?
Well, with patients, not directly patients coming to talk about this, but we've had 2 situations where the patient had spoken with their family. They were very much in line with this is what she wanted to do, what she wanted to request. This was a Spanish-speaking patient. And they came in with a lot of knowledge about the law, and this is what she wanted to do. However, she was inpatient, and her physician was not the one attending at the time, but there was a different physician who brought up herself. I don't know how to make that stop. So sorry. So this physician brought up religion to the patient herself and said, aren't you Catholic? What does your religion say about this? And at that point, the patient was very embarrassed, I think, and she decided this is a doctor that she was not known to. And at that point changed her mind and decided, no, I don't want to talk about this anymore. The physician also gave her misinformation that, you cannot have hospice if you request this medication, and that's not true. You can have hospice. So we do educate them on that, and we tried to go back and educate this patient and also, let her talk to her trusted physician, and he was very helpful, in saying, what would you like to do? But she still just decided not to move forward with the process.
I have a couple of unrelated questions, and I'll give them to both of you. First of all, what's the purpose behind requiring the patients to sit and open 100 capsules and pour that in the water? I can imagine for some people it could be torture, mental torture, to think which one of these capsules is going to do it, and I am slowly, one by one, going through this. And then my second question, which is completely unrelated to that, is when you have a physician who does not participate or refuses or doesn't support this, and you have a patient who is asking for it, and maybe they don't want to, have a conflict with their doctor or make their doctor aware of what they're doing, or how do you handle those kinds of conflicts within your hospital? Because my understanding is there are doctors who support this and doctors who do not, and patients may often be conflicted about how do I proceed when my doctor isn't supporting this, but this is what I want. Thank you.
So part 1, the pills. At this time, I think they're coming from whatever vendor or whatever, in terms of that's the way that they're coming as capsules. We have actually talked about, is there a better way to do this? From what I recall the pharmacist saying, and I wish we had a pharmacist here, but they're unable to open them all ahead of time and just leave it as a powder, because then that takes away from the efficacy, from what I understand, of the strength of the medication. So they have to maintain contained that way. So they can't mix that mixture, which I don't think we went in detail about what the medications are, is that there are actually 3 medications that are prescribed, and there are 2 pre-meds. One of them is an anti-nausea medication, and the other one is propranolol. And they take those 2 medications an hour before, and so during that hour before is when they're encouraged to get the capsules ready and start emptying them into a container, and then you add 4 to 8 ounces of liquid, and you mix it, and you take it preferably on an empty stomach. Maybe a chaser, in terms of like orange juice or something that tastes good. I mean, but at that point, it doesn't matter what your chaser is, I guess. But so that's the answer to your medication question. So I'm not sure, where we're at in terms of making it easier or better on the person that's mixing it.
So there's no purpose other than that's the best guy?
Essentially, that's what it feels like for us, in terms of our patient population and us needing to use that medication. The second question about the physicians.
So regarding the physicians, we definitely, Blanca and I try to do a lot of education at the general staff meetings for the physicians. We provide a lot of support in talking with them, going to each of their their team meetings. We also wanted to have like a more smaller group when we talked with these teams of physicians, so that they feel comfortable in asking questions. And we also do say, we understand this is a very difficult topic, and there are, even though the law states, handing them over to us or sending a referral is not participation, some people do feel like that is participation to them for their own beliefs. So if they don't come to us, it's difficult to kind of see, which those physicians are. But when in speaking with a physician, if the patient has come to us, or if somebody else, like a nurse or someone, has said this patient has asked about it, we do speak with those physicians directly and let them know this patient has asked about this. Are you a participant? And if they say yes or no, then we mention, if it's not, we do have these physicians that can take the process over and help this patient. And so we did have a physician that, he was very much against it, and it was very difficult for him. One of them sought out their own spiritual leader for themselves. But we also have chaplains, and one chaplain in particular at City of Hope, who has offered her services to speak with them. And of course, we also have the committee for the physicians at City of Hope when they need to discuss these certain things. So we do provide resources, and we have an ethics committee as well, and that meets monthly. We also have a subcommittee under ethics that is comprised of the participating physicians, Blanca and myself, our legal, to specifically discuss the End-of-Life Option Act and different things that have occurred, and concerns that were raised.
Once a patient has come to the resolve of wanting to do this, is there a typical time frame from when they've had that decision discussion to getting their script?
So the law says that the law says 15 days in between their first and second verbal to the prescribing doctor. And in between that time, around that time, they also have to see that consulting physician. City of Hope, to be safe, said it's 16 days. So what we try to do is we either immediately, if we feel that they are eligible, we ask their physician, do they meet the 6-month prognosis? Are you willing to prescribe? Would you prescribe? And then if they say no, then we say, well, then we're going to refer to another physician who can prescribe. So then that may entail going to our, one of 4 prescribers, and we have a central scheduler now for that, to see who has the soonest appointment for them to have a consultation to make that first verbal request. So that first verbal request in our policy does not count until they've made it to the prescribing physician. So although they have brought it up to Victoria or to a nurse practitioner, it doesn't count until they make it to the prescribing doc. So that starts the clock. Then they have that first appointment, then we coordinate the appointment with the supportive medicine physician, and then we have an appointment with, 16 days or more, that last one for the second verbal, and at that appointment is when they can receive their prescription and they can fill it that day if they want. We stock the medication at our pharmacy. I always let the patients know that it's not as easy to get it filled, let's say at your Walgreens or Rite Aid, because they don't carry that in stock. It's a costly medication to just have sitting on their shelves. We always have it, and we also provide a lockbox if they have children at home that they might be concerned about, or just, any concerns, and it's free of charge.
Hi. I'm curious to know if the increase in prescribing physicians comes from your current staff or new people coming in. And the second part of that, I guess, is when new staff, both support, physicians, are hired, I realize it's a very complex decision to hire somebody, but is this brought up in an interview and kind of part of the mix?
To answer this, you guys have probably the information on the first part of your question, but to answer the second part of your question, I highly doubt that that is something that's brought up in the interviews. I'm not aware of that being brought up. Now, mind you, physicians are hired in different specialties, and I'm not privy to those interviews, but again, I doubt that that is one of the things that gets brought up to be discussed.
So what we've kind of figured out is there is a new hire orientation for physicians, and I think we have a set of slides that I think they go through, or it's paperwork, documents, or something like that, that gives them education that we are a participating institution and how the law works, and then it asks them if they would also like to be a participating physician. We've also been asked to do educational presentations to the nursing residents and also the resident physicians and fellows. So we're trying to educate them.
But that's what
after they're hired. So it's not before.
After ingesting the concoction, how long does it take for the effect to have an effect on the patient?
I think it can be anywhere between a few minutes and maybe even a couple hours.
Yeah, it's so the follow-up paperwork that we have to complete once we know that a patient has taken the medication or that they've died in general. We have one of the pages asks how long did it take from when they took the medication to lose consciousness? How long did it take? So it's kind of a little bit detailed. There's like 3 detailed questions. And we send those questions to hospice and we ask them, can you help us get the answers to this? I have seen things as quick as like 45 minutes. So I haven't really seen anything super long.
Hi, excellent presentation. I wanted to ask, because you were mentioning about the statistics for the cancer patients, and when the cancer, like when there are no more treatments for that person, and obviously they start considering just no more chemos, no more anything, is that like something that you have seen, or how early in the process? It's kind of like in the timeline, I cannot really picture how early will they be able to start this process?
I mean, they can ask about it at any point, and I actually have a patient who requested this, the medication, and he thought, that he was, actually his physician had thought he was at the 6 months or less prognosis, and so at that time when the patient was told that, he asked, okay, I would like to inquire about the medical aid in dying. He saw our medical aid in dying prescriber, and at that time she felt, oh, you're actually not anywhere near this prognosis. So then he went back to his regular oncologist, continued, and about a year and a half later, asked again about the medical aid in dying, but he's still, not at the eligibility yet. But so they can ask for it at any point, but we also tell them, we can only give this prescription. You can only start the process when a physician has seen that they are at this terminal point.
Right, at the 6 months. We've had patients who have inquired and have come back like 2 or 3 times. And so we're following them on this path, on this journey with them, attending the appointments, and they're like, am I at 6 months now? No, you're not at 6 months. And then unfortunately, and that's really great. I think that's great when they can ask ahead of time and they're already framing the question, and then the physician knows what their values are and what's important to them. Unfortunately, though, in those cases like we've talked about, for example, when people go on hospice and they only, and they're only on hospice for a week, we've had some patients who've inquired about it when they are that advanced in their disease, and unfortunately, they're not able to qualify. Exactly. Yeah.
Any other questions?
If I may, I would like to make one more point, kind of back to the question of physicians' discomfort with the law and, even being considered as somebody who would prescribe this kind of a medication. As a matter of fact, a lot of physicians, if not, I don't have the exact statistics, but a lot of physicians are uncomfortable with the idea of prescribing for patients to end their lives. This is not something that physicians are embracing, by no means. But I also think if you listen to Victoria's kind of description of the policies and procedures that were implemented at City of Hope, the law is in existence. It's there, and I think that despite people's discomfort, and including physicians' discomfort about this, I think what's important is to not enable that or enable the denial of the existence of the law, and anticipate as an institution that patients will ask about this. And as an institution, as a nurse working in the hospital or a doctor, how am I going to respond to this? Who can I refer the patient to so they can have more information? Because that's what patients want. They're asking because they want to know more about that. So I think that it's upon individual hospitals and clinics to have some kind of policy in place. If this comes up, if patients bring it up, how do we respond? What kind of resources do we have for them? Because patients want that.
Anybody else over here?
I just had a question about, you used the term that the medication that's used is the safest method. And I wondered if you could speak to that. And also, it just has been making me think, as previously I was a caregiver for both of my parents at the end of their lives. And I just am really curious, how did the discussion about morphine that was readily put in our bathroom cabinets throughout, the ends of my parents' lives, how did we get to that place where these medications somehow are only being discussed in terms of this particular law, and also the, the protocol that you had was elaborate. I don't remember any kind of protocol that really spoke to, what that morphine was to be used for. And I mean, that certainly could have been used to end, someone's life as well.
So I'm the one that used the word safest, and I'm not sure if that was the best use of word, but that is the medication that has a lot of data, and has been used, has data that I remember our committee that was putting together the policy felt was appropriate for use with our patients in terms of the high opioid use that our patients have because of their pain burden. So maybe for other populations, the other alternatives are also safe and good for them. So it doesn't mean that this isn't, that the other ones aren't safe, but just that particular cocktail is more appropriate for our patients. And maybe.
I was
just going to say, and also I think when we talked at City of Hope of, are we going to do this policy? I think what they also mentioned is that they wanted to, look at Oregon and the other states, especially then, who have done it for a much longer period of time, and that's the medication that had been used at that time also. So that is the medication they felt most comfortable with also because of that.
And I believe there are mechanisms in place now, right? If the patient does not end up using it, that somebody comes in to dispose of it.
So just like a hospice does that. I mean, if all of our patients have been on hospice, and I know that one of my patients who had a plan, he told me on the phone call, he's like, yeah, so the nurse is already planning to come by and pick up all the medications that are in the house. So as I understand, that's pretty standard that the hospice will come and get the medications and take care of them so that they're not in the home.
Now, that said, to your point of especially cancer patients who have opiates at home and perhaps have been taking opiates for a while, and so their bodies are tolerant to the effects of opiates, and that's why that might not be the best medication for them to use for End-of-Life Option Act. But going back to suicides, we don't know exactly how many of our terminally ill cancer patients actually end up overdosing on their medications intentionally with an intention to end their life, and we just don't have that data. But is it happening? Most likely.
Probably.
Yeah.
Any other questions? All right. Well, I would like to give a very big thank you to Dr. Salmon, Dr. Rivas, and Victoria Ramirez. This was a very eye-opening discussion and one that we definitely need to have and have more of. So thank you very much for coming and participating today.